Today's webinar will be available on our webpage following today's presentation. We appreciate that you all are taking time to join us today, and we're grateful to you for choosing to spend part of your afternoon with us. I'll turn it over to Dr. Daskalakis in just a moment.
Hello, everybody. Thank you so much for joining. I'm sorry I'm a minute late. Thanks for being here for our COVID-19 healthcare provider update. I will be starting off, and then after me comes Sarah Braunstein. We'll be talking about some of the new news around contact tracing and case investigations. So our standard disclaimer is that our understanding of COVID-19 is evolving rapidly, and this presentation is based on our knowledge as of May 1st, 2020 at noon. I will go through current status of outbreak, talk a bit about epidemiology of COVID-19 in New York City, as well as recent scientific and clinical findings. I will then pass the baton to Dr. Braunstein, who will talk about our contact tracing task force and some interesting developments, and then we'll have some time for questions and discussion. So again, it's been nearly 2 months now since we had our first case of COVID-19 in New York City. Our community healthcare and public health systems have since really been tested in unprecedented ways. We also know that over 17,000 people have died due to confirmed or probable COVID-19 in the city. The census remains high at many New York City hospitals, so though things are looking better, we still have a lot of folks who are still in the ICU. However, there are signs that mitigation measures, including our social distancing, are making a difference. So New Yorkers really are making an impact in the absence of a vaccine or widely available treatments. These measures must be maintained until we can safely transition to containment and ultimately suppression measures. So I think everyone is familiar with this Johns Hopkins map. It is the view of cumulative cases worldwide. So you'll see that there are that almost no part of the globe is spared COVID-19. There have been over 3,270,000 cases and over 233,000 deaths. So again, showing that we are continuing to experience a massive global pandemic. Additionally, the United States shows over 1 million confirmed cases, and that's actually now 33% of confirmed global cases, and over 63,000 deaths. That's almost 30% of reported global deaths. And again, you'll see that New York City, as well as other urban centers, continue to be really the epicenter, and we are definitely the epicenter of this pandemic in the US. In terms of where we are in New York City, as of the 30th at 1:30 p.m., our laboratory confirmed cases are now to 162,212. I'll remind you that that again means lab confirmed. So individuals who have COVID-like illness who cannot get lab tests are not counted in that statistic. We have seen over 41,000 individuals who have been hospitalized. Individuals who have COVID-19 testing, 12,571 deaths occurred in those individuals, but we have an additional 5,295 deaths that we term probable, which means that somewhere on the death certificate it said COVID-19 may have been a part of their demise. Now, like I said, we do have some good news, and again, always cautiously optimistic. This graph shows influenza-like illness and pneumonia emergency department visits. So I like to look at this one not as influenza-like illness and pneumonia emergency department visits, but given what's happening in our jurisdiction, this is what COVID-like illness and visits look like. And so you'll see that that we've had a significant surge that happened very quickly in a very compact way, and it's followed by what continues to be a decline, a deceleration of visits in the emergency department. And then you'll see that this is stratified by age. So the green is 75 plus, yellow 65 to 74, purple 45 to 64, the sort of orange color 18 to 44, and then 0 to 17 is the blue line. This graph is COVID-like illness hospitalizations in New York City through the emergency department. And what you'll see is something very similar. You'll see a very compact high peak, and now we are seeing a decline in deceleration. And every day, I think now we are at 7 days under 200 admissions for COVID-like illness in New York City. So again, going in the right direction. On our website, you can also see other visualizations of cases, hospitalizations, and deaths. So you'll see first the top graph represents cases. I'll remind you that the last few days on the graph tend to experience a lag. So the low bars don't mean that we have really low bars yet. It takes a little bit of time for that number to stabilize. But the good news is that both hospitalizations and deaths, which don't have that same lag, appear to be declining in a very convincing way. So again, though we're not out of the woods, the work that you all are doing and the work that New Yorkers are doing to maintain social distance and all of the other non-pharmacological interventions that have been implemented are really showing some very significant progress in this pandemic. When you look at the cases by borough, what you'll see, the rate is highest in the Bronx, followed by Staten Island, Queens, Brooklyn, and Manhattan. And when you look at distribution of cases, the purple map on the left is total count of COVID-19 cases based on zip code. So you'll see where cases are detected. I'll remind you that cases are detected where you test. So there are a couple of areas on the map where there were very sort of significant testing programs that were looking at symptomatic and asymptomatic individuals. And so they represent a bit more of a blush. But then if you actually look at the percent of patients testing positive, what you'll see is that we do have some very significant hotspots in Queens, parts of Brooklyn, and the Bronx. So very important distribution. I think those of you who watch our maps for other infectious diseases and other diseases such as diabetes, et cetera, will recognize that this distribution really goes along with both the geographic and racial and economic inequities that all diseases do in New York City. So again, COVID, though new, does not sort of change its old tricks from other infectious diseases. And this is a graph that demonstrates deaths due to probable or confirmed COVID-19. It actually shows you in a stacked bar graph the number of probable versus confirmed cases. So again, you'll see that the good news is that we are seeing a significant deceleration in death, but that you can still see that we do have cases both who are confirmed as COVID or also who are deemed to be COVID related at the time of death. So again, some good news, more to come. And again, still not quite there from backing off from our non-pharmacological interventions like social distancing, et cetera. So this graph shows age-adjusted rates of lab-confirmed COVID-19 cases, as well as non-fatal hospitalized cases and patients known to have died. And it is rate per 100,000 by race and ethnicity. So what you'll see is that Black New Yorkers are overrepresented as cases, as hospitalizations, and as well as in fatalities due to COVID-19. And again, these are confirmed and probable death rates. Hispanic, Latino, well, actually, let's first start. It's interesting that the case bar is larger for whites and Latinos. And I think that represents a testing disparity. I presume that this will mean that white folk are more likely to be able to access testing. This is why we're detecting more cases. But you'll see that what happens is that the white non-hospitalized are higher, but then ultimately non-fatal hospitalized and confirmed probable deaths are higher among Hispanic and Latinos than white or Asian New Yorkers. So the good news is that we are getting more and more racial and demographic data every time. So our most robust views are in death and non-fatal hospitalized cases. So as we sort of go deeper into this pandemic, this data will become more and more complete, given that we have to get it from sources other than lab reporting. Also, in terms of location of COVID-19 related deaths, we have looked to see where these deaths are happening, and we've also looked at them from the perspective of confirmed versus probable. So a couple of really important observations is that confirmed COVID-related deaths tend to die in the hospital or the emergency room. Probable cases are less likely to die, although the majority do, in the hospital or emergency room. You'll also see that confirmed COVID cases are less likely to be among nursing home or long-term care residents, but probable cases are more likely to be in that environment. Again, talking a little bit about either testing practice or availability in those spaces. Additionally, you'll see that probable cases are more likely to be counted among deaths at home than confirmed cases. So again, really important data in terms of COVID-related deaths and where folks are passing away. So again, ER visits for non-COVID-19 conditions. So at least at least 1,700 of the 17,866 deaths attributed to confirmed or probable COVID-19 in New York City occurred in homes and other non-healthcare settings. Emergency department visits for non-COVID-19 related conditions have been at a historic low. So New Yorkers may be underutilizing emergency services, and this is something that has been observed not only in New York, but also in other jurisdictions around the world. So a really important observation. So it's important that we remind patients that even during a pandemic, there are some symptoms for which treatment should always be sought immediately, including trouble breathing, persistent pain or pressure in the chest or abdomen, cyanosis, alterations in mental status, seizure, signs of stroke, so example, new onset weakness or numbness in the face, arm, or leg, uncontrolled bleeding, severe persistent voluntary diarrhea, and any sudden and severe pain. We need to make sure that our patients know that emergency services are here, but even during the pandemic, and that these danger signs should trigger them to immediately seek emergency service. There are also some pretty clear factors that are associated with an increased risk of severe COVID-19 outcomes. So the data suggests that people aged over 50 have an increased risk of severe COVID-19, but specifically individuals aged 65 and older are at the highest risk. Additionally, individuals with certain comorbidities are also at higher risk for worse outcomes of this disease. These health conditions that may increase risk include cancer, diabetes, heart disease, kidney disease, liver disease, lung disease, moderate to severe asthma, obesity, and any cause of a weakened immune system. So in terms of what to tell these folks, if they have risk, advise patients with risk factors for severe COVID-19 to notify a healthcare provider if they develop symptoms of the disease. This will enable timely recognition of symptoms that require an escalation of care. So also consider proactively contacting such patients to support chronic disease management during physical distancing. So even though they're not potentially able to come see you in clinic, having a plan to reach out to your folks who have comorbidities or are older as part of your telemedicine plan is a really great strategy to make sure that they know that they're still engaged in care, even though they may not be able to physically be engaged in care. In terms of clinical characteristics of hospitalized patients, I'll start with the first one, which is a retrospective study of 393 persons admitted to 2 New York City hospitals with COVID-19. The median age was 62 years, and 61% of folks admitted to those hospitals were male. The most common presenting symptoms were cough, 79%, fever, 77%, and dyspnea at 57%. The proportion with GI symptoms, that's diarrhea, 24%, and nausea and vomiting, 19%, was actually a bit higher than in large case series seen from China. 1/3 of those individuals who were admitted in this study required mechanical ventilation. And it was notable that a substantial portion deteriorated after hospitalization. So 31% of those ultimately ventilated did not require supplemental oxygen during the first 3 hours after presenting to the emergency room. So again, really speaking to the fact that sometimes people with COVID-19 progress fairly quickly to requiring higher levels of care. Another study was a case series of 5,700 patients who were hospitalized for COVID-19 in a single New York City healthcare network. That was March 1st to April 4th, 2020. Common comorbidities were hypertension, obesity, and diabetes. Of those who were mechanically ventilated, that was 1,151, 88% died. Now, the mortality calculation only included those with known disposition at the end of the study period. 38 were discharged and 282 died. That was included in the calculation. 831, that's 72%, remained hospitalized, and they were excluded from the calculation. So patients included in mortality calculation, therefore, only had a short length of stay, that's a median of 4 days. And it may not be representative of typical course of a critical illness. Mortality may be much lower than 88% when all patients have been followed to either death or hospital discharge. So that little snapshot doesn't really give us a complete view of mortality. So though an interesting study, that may be one of the limitations. Another important clinical observation that is gaining traction is presentations of Kawasaki-like disease with cardiac dysfunction. Providers in the United Kingdom, Italy, and some US cities reporting pediatric patients with overlapping features of toxic shock syndrome and atypical Kawasaki's disease. Some of those patients were positive by PCR for SARS-CoV. Initial outreach to New York City pediatric ICUs identified 9 cases of incomplete or atypical Kawasaki's disease, and it was ages toddler to adolescent. The clinical presentation that we've heard of is fever, abdominal pain, GI symptoms, conjunctivitis, rash, lymphadenitis, myocarditis, and shock. PCR results for SARS-CoV have been positive, negative, and intermediate. So it's unclear what the relationship to this infection is. It's not yet defined, but important to remember that atypical manifestations of disease should be reported to New York City Department of Health. So incomplete Kawasaki's disease, typical Kawasaki's disease, or a toxic shock-like presentation in a patient less than 18 years should be reported by calling the provider access line, and that number is on the screen. It's 866-692-3641. In terms of serology testing for SARS-CoV, a very common question that we get, there is no evidence that people who recovered from COVID-19 and have antibodies are protected in a durable way from future infection. Current serologic tests should not be used to diagnose acute or past COVID-19 or to assess immune status. Excuse me, potential utility of currently available serologic tests really are about public health. It's serosurveys, clinical studies, and also identifying plasma donors for convalescent plasma protocols. Beyond the fact that every serology has its limits, it's also important to be cautious of numerous unvalidated and inaccurate SARS-CoV-2 serology tests that are coming into the US marketplace. So please make sure that in your practice that you are using one that has been validated, that is has an EUA, an emergency use agreement from the FDA. And remember, there's no such thing as a point of care test that is approved by the FDA for serology. So the use of those should not be done. The next question that we get always is, when can physical distance be relaxed? So we're closely monitoring key indicators to guide mitigation recommendations. Our indicators, which are available on our website, include hospital admissions, critical care capacity, and the proportion of tests with a positive result. Relaxations of restrictions will likely occur in phases. So though it felt as if a switch was flipped that brought us into social distancing, it will be a much more gradual process to return to whatever our new normal will be. It was so really that means that it's going to be instituted gradually with careful monitoring of impact to calibrate response measures and prevent resurgence. So restrictions may be retained longer in certain settings or populations to protect persons at risk for severe COVID-19. Again, you can follow these milestones every day, and on the screen you will see our website to see our milestones. So this is an example of our most exciting milestone right now, which is hospital admissions. So you'll see that we set a threshold of about 2-fold our normal level of ILI pneumonia for this time of year. And we are now currently, I believe now day 7 below that line, or maybe even longer, day 8 below that line. So we're moving in a very good direction. We're not quite there yet, but ultimately this is one of the indicators that I think will be important in conversations about moving this forward. Another indicator is people in critical care across New York City health and hospitals. So you'll see that that slowly there is movement in the intensive care unit, and we're seeing an increase in capacity. Of course, remember that this is a census count, and the capacity across hospitals has increased significantly. So it's critical during pandemic times to make sure that we have adequate capacity in case we experience an additional surge, which is why this is such an important metric as we go forward. And then this is our third, which is our percent positivity in tests. I will have you focus on the all New York City testing line. So of all tests done in New York City, what you'll see is that we are approaching our threshold of under 15%. Our New York City Public Health Laboratory has been testing individuals who are hospitalized. And so you'll see this one is more variable, but ultimately we are seeing really everything moving in the right direction to achieve thresholds to make us feel more comfortable with initiating the gradual process of removing some of our distancing and other mitigation measures. And with that, I'll pass the baton on to Sarah Braunstein, who will give you a view into the work happening around contact tracing.
Good afternoon, everyone. Hopefully you can hear me. Thanks to the organizers for asking me to speak today, and I'll be discussing, as Dr. Daskalakis said, contact tracing plans for COVID-19 in New York City. And just wanted to make clear at the outset that the planning process is very much underway, and this presentation is based on plans and discussions as of April 28th. And I'm co-leading this effort with Dr. Shama Ahuja from the Bureau of Tuberculosis Control, also at the Health Department. Next slide, please. So this slide shows the trajectory of an outbreak and different phases of the public health response to control it. So here's an example epicurve with a peak with high numbers of cases during a period without protective measures, and then a decline in the case count while mitigation measures, such as social distancing, are being implemented. And then a flattening of the curve with less burden on the healthcare system, and when we move into a suppression phase of the outbreak. And that's what we're really looking forward to now in terms of planning for the contact tracing program. Next slide, please. So as Dr. Daskalakis described, here's a recap of where we are in the New York City COVID-19 epidemic. There is still widespread community transmission of COVID-19 in New York City and around the world. And we do continue to see high numbers of new diagnoses and hospitalizations. Together, we have begun to flatten the curve, as I showed in the previous slide, with evidence of recent declines in daily case counts, emergency department visits, and admissions, all important milestones. During the eventual transition from mitigation to suppression, public health interventions will be needed to maintain control of the outbreak. Next slide, please. This next slide shows the epicurve, the number of COVID cases by diagnosis date in New York City from a period of March 3rd to April 29th. And you can see that there's a rise and then a decline more recently in daily case counts over this period, signaling that the outbreak is coming under control. Next slide, please. So to describe some contact tracing, some key steps in the contact tracing process, so that it becomes clearer what exactly we mean when we talk about contact tracing. So contact tracing is initiated with a positive test that indicates a new case of the disease, in this case, COVID-19. That case is interviewed by public health staff, educated about isolation. The case is also asked to recall everyone with whom they've had close contact during the time frame while they may have been infectious. And these individuals that are named are considered as contacts, and then public health staff notify those contacts of their potential exposure as rapidly as possible. Contacts are also provided with education, in this case about quarantine, their own risk for the disease, and then connected to testing if indicated and other services as needed to support them through the quarantine period. Contacts are monitored for development of symptoms, and those who do develop symptoms are counseled to isolate, referred for testing, and evaluated for need for medical care as appropriate. Next slide, please. And there are a number of core principles that really underscore and outline effective contact tracing programs. So first and foremost among these is the need to take all the necessary steps to protect case and contact confidentiality. But it really does start with the case investigation, in which typically the identity of the case is protected from any contacts they name. Individuals must be approached that are identified as cases and contacts in a sensitive manner. There is the knowledge that these are people both suffering from and potentially exposed to a disease, and that public health staff have to treat these interactions with sensitivity and care and concern in order also to establish trust so that data can be collected to facilitate the relationship. It is also quite important that cases are promptly identified, and that there's acting on any new illness among contacts. So contacts are typically monitored very closely for any symptom development, so that that information is alerted to public health for subsequent intervention. It is also critical to provide comprehensive wraparound services so that additional interventions like isolation and quarantine are safe, feasible, acceptable, and effective. This is particularly important for a disease like this that is hitting certain communities particularly hard who have multiple other needs. In New York City, the health department staff, like epidemiologists, public health nurses, public health advisors, routinely conduct contact tracing for diseases such as tuberculosis, HIV and other sexually transmitted infections, measles. The health department has a very long and strong record with respect to effective and sensitive contact tracing for a range of infectious diseases. Next slide, please. So this is a sort of high-level diagram of how the New York City COVID-19 contact tracing program is developing, with steps moving from the left side of the arrow to the right. So first, as I mentioned earlier, a test is ordered by a provider, and its result is positive for SARS-CoV, and that is reported typically electronically to the health department. So that's our first notification that there's a new case of disease. Information comes along with that test to identify and provide contact information for that case, and the case is interviewed by public health staff, and the case is instructed and educated to self-isolate. Contacts are elicited from the case during the case investigation using a dedicated contact definition, and then contacts are notified and educated about their own COVID-19 risk and described and recommended to self-quarantine until at least 14 days after their last exposure to the case. For both cases and contacts, needs are assessed for supportive services that can support and make feasible isolation and quarantine. And those cases and contacts indicating needs are connected to a daily monitoring program. And so this is the daily active monitoring program, is the program during which, the phase during which cases and contacts will check in, typically daily, with health department staff to report on illness, any symptom development among contacts, needs for supportive services, so that public health staff can then make referrals to those supportive services, including medical care, critically. Next slide, please. So I just wanted to flag the importance and complexity of contact tracing in congregate settings. We know that for that contact tracing of patients with COVID-19 who are potentially exposed at work, and patients in healthcare facilities, for example, and other patients living in residential and non-residential congregate settings is complex and will require specialized protocols and staffing. So these priority settings may include nursing homes and other long-term care facilities, homeless shelters, adult living residences, correctional facilities, and housing that may be crowded and or multi-generational. So we are very much attending to these specialized settings in the development of our contact tracing program. Next slide, please. New York City contact tracing efforts for COVID are going to require a scale up that is quite unprecedented. And to do so, we will need to develop a workforce given that very large scale of this effort. And contact tracing is a specialized skill set that requires a strong, scalable network of staff that have relevant knowledge and skills. And among these are really an ability and understanding to maintain patient confidentiality, an understanding of the relevant medical terms and principles, those that relate to COVID-19, for example, the exposure, how exposure happens, definitions of infection, the infectious period, the incubation period, symptoms of disease, and pre-symptomatic and asymptomatic infection. Generally, and here for this disease as well, workforce needs to have excellent interpersonal and interviewing skills, basic skills in crisis counseling and the ability to refer patients and contacts for care and services. Very importantly, because we need to do all of this work and develop and design this program with an health equity focus, the workforce will need to have cultural competency and understanding of the local communities that are being affected by this disease. And these jobs are done by people in roles such as disease investigation specialists, public health nurses, community health workers, public health social workers, and epidemiologists. And those are the types of people that we will be hiring to scale up this contact tracing effort for COVID-19 in New York City. Next slide, please. So when might the contact tracing program begin? As Dr. Daskalakis described, the health department is closely monitoring a range of public health milestones to understand the phase of the outbreak and when we're moving into a suppression phase. And these indicators, again, include hospital admissions, critical care capacity, positive test rates. And alongside those, we're currently developing the data systems and the workforce to support the contact tracing program launch, and feel strongly that those infrastructural aspects for the program need to be in place in order for us to launch it. Next slide, please. And I'll just end by sharing a number of resources on COVID-19. There's a wealth of resources on the New York City Health Department's page, webpage. There's a provider page that I'm sure you're familiar with, the data page, these weekly webinars, dear colleague letters related to COVID-19 and the New York City HAN, and then other sources more broadly around COVID that include information on contact tracing for COVID-19 on the CDC's website, the Vital Strategies and Resolve to Save Lives website. ASTO and NACHO are also two professional groups that have a lot of content both on COVID-19 and on contact tracing specifically. Next slide, please. And I'll end there. Happy to take any questions. Thank you.
Thank you to Dr. Daskalakis and Dr. Braunstein for this important information. We do have some time for the remaining Q&A, so as a reminder, please submit your questions via the Q&A section of the WebEx text box. And, we're assisted with the questions today by Dr. Jennifer Rakeman, Assistant Commissioner and Lab Director at our Public Health Laboratory, and Dr. Mary Foote, Healthcare Systems Planning Lead for our Outbreak Response. All right, so there are some questions about what is the process for somebody seeking diagnostic testing? So it does depend. The H&H sites are walk-in, and Dr. Mary Foote has put some more information in the chat box and in the Q&A about numbers you can call for more information about that as well. If you're looking for COVID-19 death breakdowns by neighborhood, the information should soon be available on our data site expansion if it's not there already. Let's see, there's some questions about how researchers know racial breakdown for patients. Most of the data on race is either self-reported or extracted from RIOs, and it's not available for all reported cases. Let's see. Data on alternate care sites is forthcoming as well for those who are asking. There is a question about partial Kawasaki cases that are treated or managed as Kawasaki cases. We do have Julia Schillinger here to help assist with some of those questions if she's able to speak on those. I think we may be having some audio difficulties on that, so perhaps she will be able to join us in the chat. Putting it out there to those of our other panelists on the line, there's a question: is there a thought that encouraging the most vulnerable populations to go to testing centers is putting them at risk when they might be told to quarantine anyways?
Dr. Daskalakis, I don't know if you want to speak to this. This is Sarah. I can just mention that that is something that we, in conjunction with other colleagues working on the testing components, are very cognizant of, and are exploring multiple options to make testing, if needed and when needed, safe.
Thank you. Another question is about indicators for percent of tests. This one might be a good one for Dr. Rakeman if she's available. If one of the indicators is percent of tests that are positive, can't that be biased because more testing facilities are now loosening criteria to obtain testing? Okay. Maybe we're having some audio issues with our other panelists, but that is absolutely correct. And certainly something that we are doing our best to consider as testing becomes more readily available. This question as to whether there has been an association found between people who've had a flu shot and severity of COVID-19 infection, and we are not aware of any association.
And I can just, this is Dr. Wright, I can just speak to that a little bit. So there is no relationship. The flu shot does not protect you from COVID-19 as far as we are aware. But there is also, I think there was a perception that I've heard in some questions that people asking from the public that you cannot get the flu if you have COVID, or that you can only get one of those at a time. And there are a few, there was a big paper from Singapore, but there are a few other papers and a few other cases where we have seen people getting more than one virus at the same time.
Thank you. So as a note, when contact tracing begins, we are doing our best to currently rapidly scale up quarantine sites. To answer some questions about that. How long are individuals who test positive instructed to isolate? At least 7 days since symptoms started. Never had fever, or you've not had a fever for the prior 3 days without the use of fever reducing drugs, then your overall illness has improved, then you can do your best to step outside with caution and a mask. When is a recovered COVID-19 patient positive not contagious?
So it's Dr. Ray again. So I think that we are, as Dr. Foote indicated in the chat box, we're still learning a lot about that. And that also speaks to some of the questions we have around testing and what does this test mean and what does it mean if I've already had the illness. And the issue is that we don't actually know what that means. So for example, for many of the tests, we can say what the test says, but we can't answer the question, when can I pass the disease to another person? And we can't necessarily answer the question, when am I immune from getting the disease again? And that's part of why it's still important to stay at home. And, especially in those 7 days after you have symptoms, or, if you've had a fever in the last 3 days.
Is DOHMH still recommending against testing outpatients? If so, when might that recommendation change in order to promote contact tracing? Sorry, can you repeat the question? Oh, sure. Is DOHMH still recommending against testing outpatients? If so, when might that recommendation change in order to promote contact tracing?
So I think that there, as Dr. Foote has said in the chat box, there are a couple pieces involved in that. One of them is just the supplies involved for testing, and that's not just the tests themselves, but it is what healthcare workers, if healthcare workers need to apply the tests and lab personnel need to run the tests, whether we can protect those personnel as well. Additionally, there's the information that we can get from a test. Does the information change the behavior of an individual? So if we do have widespread community transmission, then does the test actually change whether I'm staying at home if I feel sick, or does it change whether I'm staying at home if I'm well? And I think that there's a knowledge and a policy component as well, and I think just the overall information we have about the prevalence of the disease in the city and how much our hospital capacity is. So it's a very long answer to say that it is complicated, but we will keep everyone updated. We seem to be having some difficulty unmuting our other panelists to help assist with some of our Q&A, so we apologize, but they are doing their very best to answer the questions in the Q&A, and we can also make these answers available after the webinar has concluded as well. So thank you for bearing with us. We did have another question. Is there consideration to use community health workers for contact tracing, as they usually have the trust of patients and community residents? Yeah, and again, you can certainly look in the chat box for the answers, but Dr. Foote is absolutely correct that there are large efforts done to hire real New Yorkers for contact tracing, and there is a concerted effort to get people from impacted communities so that they can do tracing within their own communities among their neighborhood.
As a note, if you do have questions about Kawasaki's, please submit them in the Q&A, because we will be able to answer them there.
Whatever.
All right, we're still having some issues, so we may have to end our webinar a little early today, but we did want to get to a few more questions. Somebody asked how to locate previous webinars on our website, and it is under the Webinars and Presentations tab at, if you go to nyc.gov and then our COVID-19 providers page.
Yes, and I think we did have we had a question on the contact tracing workforce and how many will be multilingual to interview households. Is Sarah, do you want to talk about the different language capacities you're
Sure.
looking at?
Sure. Yeah, I just responded in the chat maybe to this question, but we have provided our colleagues who are running the hiring with the most common languages spoken in New York City, and are aiming to hire at least a good proportion of the contact tracers who can speak those languages. For languages that come up among cases and contacts that are not among those most common ones, we will use a language line so that we can make sure we're able to interact with and outreach to all people as needed.
And if community-based organizations or others have more questions about where they can send people to sign up for that kind of work, can you give more information about how to do that?
Sure. The postings for the contact tracer positions are on the website of the Fund for Public Health New York. I believe their website is fphny.org. I'm not sure if there's a C in there, NYC, can't remember at the moment. But if you just Google the Fund for Public Health New York, and they have a careers page on their website, and the postings are there.
Great, thank you very much. And I know that is an ongoing effort with the Fund for Public Health in New York. For those, we did have a few questions from community-based organizations who want to make sure to connect, especially people who have language capacity, to those positions. Our next question, if a patient had the disease at the beginning of March when testing was not easily available, would they show up positive if they've recovered?
This is Dr. A, and again, we'll have Dr. Rigman soon, who is the lab expert, but I'll answer to the best of my ability. And I think the question says, would the test show up positive? And I think this gets to the fact that there are several tests out there. So there are swab and PCR tests. And, at the beginning of March, it's probably unlikely that the swab will show up positive, but there are reports of nasopharyngeal swabs, which is the ones that go deep into the back of the nose, showing up positive with pieces of virus for weeks and weeks on end in some patients. We're not 100% sure what that means. There are antibody tests, and I think we have addressed both in the chat box and other calls that there are different antibody tests. And I guess the answer is we really don't know. It depends on the tests, and it depends a lot on some of the sort of the course of the disease and the science of the disease and immunology around it that is still evolving.
Thank you, Dr. A. Another question about what are next steps for patients after testing, especially for patients who are high risk? Are they being referred to physicians who are able to provide early intervention in order to impact death rates? And Dr. Mary Foote did provide an answer to that in the chat. We do have a HON coming out about ensuring high-risk patients are recognized and followed. But yeah, this is an ongoing and extremely important issue for us. Maybe Dr. Braunstein, if you could assist with this, will DOHMH be launching an educational or informational program on contact tracing for the general public? as many of our partners are getting questions regarding anxieties around that.
And around civil liberties and the protection of information in particular.
Yes, understood. We are in discussions with colleagues at the health department who are part of a public messaging group whose objectives are broad with respect to the city's response to the COVID-19 outbreak. But we are in discussions with them about public messaging that will accompany the contact tracing program once it's launched, that explains what it is, what it's not, how it's proceeding, and the various attention being paid to the legal, ethical, social implications. Yes.
Thank you. We did have a question about the percentage of positive cases that don't report race. And we would have to point you to our data site for more of that information right now. And if it's not available, we hope to have it available soon.
Yeah, and I think that just broadly, with reference to this question, you know, our epidemiological data, when we first put it out, you know, there were, and I am sorry off the top of my head, I don't know the percentage that are not reporting it, but it is on our website. The percentage that didn't report race was, or where we didn't have a race, at least around death outcomes, was very large. And so what happened is the race with the highest risk of having the outcome of death with COVID-19 was listed as Hispanic, and currently it is African American or Black. And so again, it's a really important reminder to check all of that information is listed together with the data and with those graphs. They might be, you know, in a little footnote at the bottom, but please be very careful when you read all of those data, because we put a lot of work into making sure that everything is there for you to be able to interpret it correctly. And again, our website, if you go to www.nyc.gov/coronavirus, there's a link to the health department at the very top of the page. And there's a drop-down menu where you can go to a very, very extensive data section. And I see that there's a question about sharing the PowerPoint and the video. So on our website, again, nyc.gov/coronavirus, click on the health department website. There's a whole section on information for providers. And under that, the webinar video and slides will be made available publicly. It's usually up by late Monday, and today's Friday.
And on that note, I think we will say thank you again to Dr. Braunstein and Dr. Daskalakis for joining us and sharing that information with us today. As Dr. Ray noted, you can find all of it on our website by early next week at the latest. And you can also go to the website for the Fund for Public Health in New York if you're interested in connecting community members or other professionals to those contact tracing positions. We thank you again for joining us today, and we look forward to sharing more information with you soon.